Welcome to the deep dive. Today we're tackling a really common topic, something you'll definitely see, inguinal hernias.
Absolutely.
So basically it's when stuff from your abdomen, maybe like a bit of bowel, pushes through a weak spot down in the groin area,
Mm-hmm.
and you might feel or maybe even see a kind of bulge there.
That's the classic sign, yeah.
We've got your revision notes right here, and the plan is to really pull out the essential high-yield info, make it stick for you.
Exactly. Think of this as like your focused revision session on inguinal hernias. We're going to cover the definition, what causes them, the risk factors,
Right.
how it actually happens in the body,
Yeah.
what else it could be, the differentials, how common it is, the epidemiology,
Okay.
the clinical features you'd see, how we investigate, manage it, the prognosis, and importantly, the complications. We'll try and use some memory aids too.
Perfect. Let's jump right in. Definition first. What exactly is an inguinal hernia?
Okay, so an inguinal hernia is a protrusion, basically a pushing out of abdominal contents.
Yeah.
Could be intestine, could be fatty tissue,
Right.
through a weak point, specifically in the inguinal canal.
That passageway in the groin.
Precisely.
Yeah.
And like you said, the most obvious sign is often that lump in the groin. You can usually see it or feel it, and it's super common. It actually makes up about, 75% of all abdominal wall hernias?
75%? Wow.
Yeah, it's the big one. And here's a key thing to remember. Overwhelmingly more common in males. About 95% of cases.
95%.
Yeah.
That's really significant. The notes also mention direct and indirect types.
They do, yeah. We'll dig into the difference between direct and indirect a bit later when we talk about clinical features. But for now, just lock in the core definition. Abdominal contents popping through a weak spot in the inguinal canal. Very common, especially in men.
Got it. Okay, so what causes this weak spot then? What's the etiology?
Well, the fundamental issue is a weakness in that abdominal wall. And this weakness can come about for a few reasons. Sometimes it's congenital. You're born with a bit of weakness in the inguinal canal. Maybe it didn't quite close up properly after the testes descended in males.
Ah, okay, so from birth.
Yeah. Or it can develop later. A big factor is increased pressure inside the abdomen.
Right.
So think about things like chronic heavy lifting, especially with bad technique.
Right.
A persistent cough, like in COPD, or even being significantly overweight, obesity. All that puts extra strain on the abdominal wall.
Makes sense.
And, just getting older plays a part too. Tissues naturally weaken over time, so it's kind of a mix. Could be congenital, could be increased pressure, could be age.
Born with it or it develops due to strain or age.
Okay.
Yeah.
That leads nicely into risk factors. Who's most likely to get one?
Well, number one, as we keep saying, is being male. That's down to the anatomy, the whole inguinal canal setup.
Right, the 95%.
Exactly. Then advanced host tissues just get less robust. A family history is also important. If your dad or brother had one, your risk is higher. Suggests a genetic link, maybe?
And then anything that chronically bumps up that abdominal pressure. So connect it back to the causes. That chronic cough,
Yeah.
chronic constipation where you're straining a lot,
Yeah.
obesity, and occupations or hobbies involving regular heavy lifting. You can almost tick them off. Male, older, family history, coughing or straining, overweight, lifting heavy stuff.
That's a really useful checklist.
Yeah.
Okay, pathophysiology. Let's get into the mechanics, what's actually happening step by step.
Right. So step one, you've got that weakness, that little defect in the abdominal wall. Step two, something pushes through it. Usually it's a loop of bowel or maybe some omentum, that fatty tissue.
Yeah.
And what drives that push? It's either that inherent weakness from birth or it's that increased intra-abdominal pressure we talked about.
The coughing, lifting.
Exactly. That pressure finds the weak spot and forces something through. This creates that bulge or swelling you see or feel in the groin. And often there's discomfort, maybe a dull ache or even pain, particularly when you do things that raise the pressure, lifting, coughing, standing for a long time. Now, the really crucial bit here is remembering the potential complications if it's not dealt with. Think SI, strangulation, and incarceration.
That's I.
Yeah. Strangulation is bad news. That's when the tissue trapped in the hernia loses its blood supply. It can die off. Surgical emergency.
Okay, that sounds serious.
It is. And incarceration means the tissue is trapped, stuck in the hernia sac, and you can't easily push it back in. It might not be strangulated yet, but it's at high risk of becoming so. Both need urgent attention.
SI for serious issues. Good mnemonic. Now, someone comes in with groin pain and a lump. It's not always an inguinal hernia, is it? What else should be on our radar? The differentials.
Absolutely. Differential diagnosis is key here. So number one to consider is a femoral hernia. They also present as a groin lump, but typically they're a bit lower down and more towards the inner thigh compared to an inguinal hernia, and they're often harder to reduce.
Okay, location is key there, lower down.
Yeah. Then you've got a hydrocele, which is fluid collection around the testicle and the scrotum. It can be confused with an inguinal hernia that extends down into the scrotum, an inguinoscrotal hernia. But a hydrocele usually feels different, more like a smooth, fluidy balloon. You can sometimes transilluminate it too.
Ah, okay. Fluid versus bowel, potentially.
Right. Then a lipoma, just a benign lump of fat under the skin. It'll feel like a lump, but it won't reduce and it won't have that cough impulse.
Just a fatty lump.
Pretty much.
Yeah.
Also, think about inguinal lymphadenopathy, swollen lymph nodes in the groin. You usually look for other signs, maybe an infection somewhere nearby, or other reasons for swollen glands.
Makes sense. Look for the cause.
Exactly. And then there are less common things. A spermatic cord, hydrocele, an abscess, maybe a Saphina varix, which is related to varicose veins, a varicocele in the scrotum, even bleeding, or an undescended testis. A good mnemonic some people use is filth. Femoral hernia, inguinal nodes, lipoma, hydrocele, and then T for the rest, or testis issues.
Filth. Okay. Femoral, inguinal nodes, lipoma, hydrocele, the rest. That's helpful. So how common are these things? What's the epidemiology look like, especially here in the UK?
Oh, they're really common. In the UK, inguinal hernias account for something like 7% of surgical outpatient visits.
Wow, 7%.
Yeah, and that male predominance we mentioned. For groin hernias overall, it's about an 8-to-1 male to female ratio.
8-to-1.
Even in babies, it's around 1 to 3% in full-term newborns. And the rate in men just climbs steadily with age. Really shoots up from, say, 16 through to 75 plus. So the takeaway is very common, especially in older men, and a frequent reason people end up having surgery.
Those numbers really paint a picture. Okay, so clinical features, a patient walks in. What are the classic signs and symptoms we're looking for?
Well, the absolute hallmark is that lump, visible or palpable in the groin.
The bulge.
The bulge, exactly.
Right.
Patients often describe discomfort, maybe an ache or a dragging sensation, rather than sharp pain unless it's complicated. And typically gets worse with activity lifting, coughing, standing up for a while. A really key feature for a simple, uncomplicated hernia is that the bulge often disappears when they lie down. It reduces.
Goes back in.
Yeah. But you need to be alert for the signs of a non-reducible hernia. That's when it doesn't go back in. If that's combined with severe pain, maybe feeling sick, vomiting, those are red flags. Could be incarceration or even strangulation happening.
Okay, red flags noted. And during the examination, what are we focusing on?
You want to confirm that groin lump. See if you can gently push it back and assess reducibility. Note any tenderness. Ask about the discomfort. When does it happen? Does it worsen with activity? And crucially, you want to feel for a cough impulse.
How do you do that?
You place your fingers over the lump or the area of the inguinal canal and ask the patient to turn their head and cough. If you feel a distinct push or impulse against your fingers, that's highly suggestive of a hernia. Abdominal contents are being pushed out.
Got it. Feel for the cough impulse.
Definitely. And remember, those types, indirect and direct. Indirect is more common, often congenital, follows the path the testicle took, can go to the scrotum. Direct is more often acquired, pushes directly through a weakened back wall of the canal, less likely to go into the scrotum. Think I for indirect goes inside the deep ring following the cord. D for direct pushes directly through the wall.
I inside, D directly. Good one.
Yeah. And always examine standing and lying down. A hernia might only be obvious when standing. Remember, congenital ones in babies need urgent referral. In older kids and adults, they can develop more slowly, but they always have that potential to become irreducible or incarcerated.
Okay, thorough examination is key. So once we've done the history and exam, what about investigations? Do we always need scans?
Often, no. The diagnosis is usually clinical. History and examination are paramount. But if there's uncertainty, or maybe you suspect a complication, imaging helps. Ultrasound is usually the first port of call. It's good, it's non-invasive, readily available. It can confirm there is a hernia, see what's inside it, bowel, fat, and check for complications like strangulation.
So ultrasound is the go-to imaging.
Generally, yes. Sometimes, particularly if it's complex or maybe a recurrent hernia after surgery, or the diagnosis is really unclear, an MRI or a CT scan might be used for a more detailed look. But things like herniography, using X-ray contrast, are pretty much historical now. So mostly clinical ultrasound if needed.
Okay, that makes sense. Clinical first, ultrasound backup.
Right.
Management, how do we treat these?
Surgery. Surgical repair is the definitive treatment for symptomatic inguinal hernias.
Right.
And there are basically two main ways to do it: open surgery or laparoscopic keyhole surgery.
Okay, open versus keyhole.
Yeah. Open surgery involves making an incision directly over the hernia in the groin. There are different techniques, but the most common one nowadays is the Liechtenstein repair, where a synthetic mesh is placed to reinforce that weak area. It acts like a patch.
The mesh repair.
Exactly. Laparoscopic surgery uses a few small cuts, a camera, and special instruments. The surgeon repairs the hernia from the inside, again usually using mesh. This approach is often preferred for bilateral hernias, meaning on both sides, or for recurrent hernias, ones that have come back after a previous open repair.
Any advantages to laparoscopic?
Potentially quicker recovery for some activities, maybe less chronic pain for some patients, and often a lower risk of wound infection. But both open mesh repair and laparoscopic repair are very effective. Mesh is generally recommended because it significantly lowers the chance of the hernia coming back compared to older non-mesh repairs.
So mesh is standard now?
Pretty much standard, yeah. There are lighter meshes now, too, addressing some older concerns about discomfort. Now, what if the hernia isn't causing any problems?
Yeah, what then?
For some people, particularly older individuals with perhaps other health issues, if the hernia is small and completely asymptomatic, watchful waiting might be considered, just keeping an eye on it. But that's a discussion between the patient and the surgeon.
Okay.
Using a hernia truss, like a supportive belt, is generally not recommended as a long-term fix. It doesn't cure it. And obviously, if a hernia becomes incarcerated or strangulated, that's an emergency, requires urgent surgery.
Right, no waiting then. What about kids? Is it different for them?
Yes, the threshold for surgery is lower in children because the risk of incarceration is higher. For healthy, full-term baby boys with a straightforward, reducible hernia, early surgery is usually the way to go.
And the surgery itself?
It's often simpler, usually just a herniotomy, where they find that persistent little tunnel, the patent processusvaginalis, tie it off and remove the sac. Often doesn't require mesh, like in adults.
Okay, simpler procedure for kids. And recovery after surgery for adults. How long are people usually out of action?
It varies, of course, depending on the type of repair and the person's job and activity level. But generally, people get back to normal activities within about 2 to 6 weeks. Often, especially with laparoscopic or straightforward open repairs, it can be done as a day case, in and out the same day.
2 to 6 weeks, potentially day case. That's pretty good. So after treatment, what's the overall outlook, the prognosis?
Generally, really good. Excellent, in fact, with appropriate surgery. The repair fixes the hernia, gets rid of the symptoms.
That's encouraging.
Yeah. Now, there is a small risk the hernia can come back recurrence. But with modern mesh techniques, that rate is pretty low, maybe around 1% overall, though it varies.
1%, okay.
Lifestyle plays a part too. Avoiding things that increase abdominal pressure long-term can help prevent recurrence or new hernias elsewhere. And of course, other health problems, comorbidities, can influence the overall picture. But for the hernia itself, prognosis is usually very positive.
Mostly good news with treatment. But we should talk about complications. What can go wrong, either if it's left untreated or even after the surgery?
Okay. Complications. Untreated, the big scary ones are strangulation and incarceration, like we said. Loss of blood supply, tissue death, really serious.
Right, the LIS.
Exactly. After surgery, the main thing people worry about is recurrence. Although it's low risk, around 1%, it's most likely to happen within the first 5 years if it does occur.
Okay.
Some patients, unfortunately, can develop chronic pain in the groin area after surgery. It's not common, but it can be troublesome.
Chronic pain.
Yeah. And then you have the more immediate post-op things. Bruising is common, maybe a small collection of blood called a hematoma. Wound infection can happen, though less common with keyhole.
Standard surgical risks?
Pretty much. There are factors that increase recurrence risk, being very young in kids, older age in adults if the hernia was incarcerated at the time of surgery. Ongoing issues that raise abdominal pressure, like chronic cough, prematurity in babies, certain hernia types like sliding hernias, and very rarely you can get serious complications like damage to the blood supply of the testicle or ovary leading to atrophy, or accidental injury to the bladder or bowel during surgery, or hydrocele formation later on. But these are uncommon with experienced surgeons.
So while surgery is effective, there are still potential downsides to be aware of.
Right. Well, that's a very thorough run-through of inguinal hernias. Covered a lot of ground.
We certainly have. I think the main takeaway for your revision is inguinal hernias are common, especially in males. Surgery is usually the fix and works well, but you need to know about the red flags: incarceration, strangulation, understand the difference between direct and indirect, the investigation pathway, and be aware of potential complications like recurrence and chronic pain.
Absolutely. Crucial stuff to have clear in your head. And remember, if you want to test yourself on this or explore other MSRA topics, head over to pastthemsra.com.
Yeah, great resource. And for loads of excellent free materials to help with your MSRA prep, check out freemsra.com. Brilliant. Thanks for joining us for this deep dive into inguinal hernias. We'll catch you on the next one.